Thank you very much for joining the first webinar of the year. And just before I start, can you put a little comment in the box if you're getting audio through correctly, just so that we know that it's coming through. So just type your name, type your country, type yes, anything in there just to tell us that you're getting the sound coming through. Now, if you stay till the end, we've got some things for you. We nearly always get everyone stay to the end, but we thought, everyone listens so well, we'll give them some bonuses. So for those of you in countries that have particular CPD requirements, so where you need to have a particular type of form like the UK or New Zealand or the US, once we get all the data in, then if you stay to the end, we can send you a 1-hour continuing education certificate. We'll also have the checklist that I use for impressions and the supply list, so all the equipment, all the materials and so on that we'll send out to you. And also there's footage of me controlling tissue and taking impressions. So this is all stuff that we'll give you free if you stay till the end. Now, what I'm going to talk about today is something that you would want me to just give you some easy tip, like we could just give you some new impression material or some technique or something that's going to make it easy. I can't do that for you, okay? I'm going to show you a methodical series of steps, and if you follow all of them, you will get impressions. But the problem is that what we're talking about with impressions is actually not mostly with our hands. So you think of it as a technical exercise, but it's mostly a mental one. And I can give you a little example of this. So today I did a full arch prep. So my first patient went from 8:30 this morning until lunchtime. That's assuming I get lunch. And the preps on the front teeth were slightly above the gingiva. The gingiva was super healthy, and I was a little bit tired. And I'm a little bit tired because I stayed up a little bit late working my webinar last night. So you can see that there's some things going on there which have nothing to do with anything technical. I know how to prep teeth, I know how to take impressions, I know that I'm going to teach you about impressions today, I know exactly the steps I need to go through, and I didn't do them. And why didn't I do them? Because I was tired and I was lazy. And so most of the problems that you have with impressions have nothing to do with your hands, your technique, or your materials. They are because of a thing called human factors. Now, we don't get taught human factors in dentistry, but we should. Human factors is almost only taught to pilots, and it's taught to pilots because the most difficult thing they do is land a plane, and they do it at the end of the procedure, so when they're tired. And when we take an impression, we do it at the end of the procedure when we're tired. It's the most important part of the whole thing. That's the data that gets recorded. It doesn't matter whether you take it with silicone or with a scanner. That is the data that you're going to send off. That's what everything is going to get built on. So it's the most important thing, but we do it at the end when we're tired. And so today, I thought maybe I can get away with no retraction cord, not doing all the usual 30-40 minutes of putting cord in, and I took the first impression and it was terrible. I put the second impression. So today I was just reminding myself why you have to do it the way I teach, or something similar to this, to get perfect impressions first time. So there's really 6 parts to getting an impression. And the first part has nothing to do with technique, it's scheduling. Every dentist, now all of you dentists, go and ask your dental assistant how long you actually take to do a crown prep. If you're like me, you think that you take 10 minutes less than you really take. So if it takes you 60 minutes to do anesthetic, prep, core build-up, retraction cord, impression, temporary, then you will think it takes you 50 minutes. Now, I don't know why, as dentists, we always think we're faster than we are. Maybe we just want to feel good about ourselves. Maybe part of it is we start thinking about, it costs so many dollars an hour to pay all these staff, who knows what. But we always want to give ourselves too little time. Now, it doesn't really work because it makes you stressed. It makes you not feel good about your work. And I don't think it's actually any benefit financially. Even though I do it, you do it, everyone does it. The second one is tissue control. So controlling the tissue both during the prep and during the core build-up and during the impression is absolutely crucial. And what do I mean by tissue control? I just mean that it's not a bloodbath. It's so easy when we prep. So often the teeth that we're prepping, they're rough, they have plaque all over them, they've had margins that have overhung, they've got subgingival margins. So you'll see some people will get up and they'll lecture and they don't have an unhealthy patient in their entire practice. My patients have plaque, they have calculus, they have overhangs, they have all sorts of things. And so it's quite common for my patients to have gums that bleed. Cores. The core is one of the most important parts of your impression. And I'm going to tell you about that in a moment. And so is the prep. So the way you prep and the way you do your core is incredibly important to how well either an optical scanner can scan or how well silicone can run over the prep. And so if you prep in a certain way, it's almost impossible to get a good impression. You will take it 7 times, or you will just send it to the lab, but you don't send it to the lab technician that you like, you send it to the one who doesn't know you, so that when he's sitting there going, oh, what's this? It's a dog's breakfast. Then he's doesn't know your name. I've done that before. Okay, retraction. Okay, retraction, you can use electrosurge, you can use laser. What I'm really talking about is creating a trough between the gingiva and the tooth that is wide enough, and that's the really important part, wide enough. And the last one is the impression. That's probably the least important. So the least important part of getting a good impression is the actual impression material, trays and all that sort of thing. The most important part is the 5 steps that come before that, but we tend to focus on the 6th one, and that's why we often get bubbles, we get drags, we get missed impressions and so on, okay? So let's talk about scheduling. To do things right, you need to be calm, and you need to be able to focus step by step by step. And if you can't focus on those steps one by one and complete them properly, because you're starting to panic that you're running late, then you start to cut corners, and then what happens is that because you don't complete all the steps correctly, then you're so much more likely to get the last step, which is the impression, wrong, and then you take it again and again and again. So by rushing at the start, you failed at the end, and then you actually took longer. Now, there was a person who taught me about this. It was a patient of mine who was in the SWAT team, and he was the firearms instructor. He taught the SWAT team in my state how to jump into a room, and if someone's holding a gun to someone else's head, they would still shoot them faster. And his technique was slow is fast. And what he meant was that it didn't matter how fast you reached for the gun, it actually only mattered how fast you lifted it up. It didn't matter how fast you shot, it only mattered how fast you hit something. And so it is like that when we are doing impressions. It doesn't matter how fast we get to the impression if we take it 7 times, or if the crown doesn't fit because the impression was terrible. So it matters how quickly we finish, not how fast we jump through the steps. And when you go through the steps slowly and surely, then you get the impression first go, which saves time on the end, and then your crown fits better, which saves time on the end, and it looks terrific, and you don't have to replace it and so on. And not only that, but when you take enough time, you actually enjoy your work and you feel good about it. And it fills your schedule up quicker, and then you get booked out, and then you can either employ more people or you can put your fees up, whichever you prefer. Tissue control is probably the simplest from a technical point of view. It's very simple, but it's incredibly important, and it's so easy and so hard at the same time. Now, this is what you need. This piece of equipment is what you need to get tissue control. It costs 100,000 euros, and if you buy that, it will solve all of your problems. Okay, I'm telling lies. Okay, you need 3 things, and they're very cheap. And you have one thing which takes discipline. Viscostat Clear. Okay, there's lots of astringent type medications and so on. I've used Viscostat Clear for 11, 12 years now. I've got no chance of it. It's aluminium chloride. It doesn't stain things. So if you use anything with iron, it can stain. Iron is fine if it's for cementing. So if you're doing a cemented crown, you're doing a PFM, you're doing porcelain fused to zirconia, that is fine. But a lot of times we're bonding or we're using zirconia, and we don't want to have black or brown margins. So I always use Viscostat Clear. It will stop Unless the patient is taking Xarelto or warfarin, it'll stop any bleeding. Almost any bleeding. There'll be one of you that sends me a message tomorrow and says it didn't stop the bleeding. Okay, so almost any bleeding. Cord. I always use UltraPack. There's other cords. I like UltraPack because it doesn't fray. It's woven, and the amount that you're using, it doesn't really matter what it costs. It doesn't matter what type of cord it is. If you use a coarse diamond burr near it, you can get that thing where you're sitting there concentrating on the prep, and then suddenly it turns into a helicopter and frightens the life out of you. So no cord will stop that. Teflon will not helicopter, but cord will. So if you're prepping near cord, use a fine burr. And cotton wool. Now, I actually don't buy cotton wool balls. I pull the cotton out of the end of a cotton roll. And one of my staff was trying to do it for me today, and she was trying to use tweezers. I'm not sure why she was trying to use tweezers, but I don't use tweezers. I just grab it with my finger and I pull it out. And that's the best way to get the cotton wool out of, for doing tissue control. Now, cotton wool, you soak it in the Viscostat Clear and then you pack it wherever it's a bloodbath. So you can't use cord. So when you prep, sometimes there's like a subgingival margin and it's bleeding everywhere. You can't use cord when you've got blood going everywhere. You have to use something that will pack a wide area, and that's when I use cotton wool. Now, you need to remember, slow is fast. So with retraction or with tissue control, the more you try and make the tissue stop bleeding, the more it bleeds. So you can't keep poking at it. You can't put the cord in and pull it out. You can't put cotton wool in and pull it out. You can't keep putting things in. You have to put it in and wait. Now, if it's bleeding a lot, you need to wait 10 minutes. If you try and do it sooner, you're just going to get stressed and you're going to take the impression 7 times, and the impression is going to be rubbish because it's going to have blood everywhere. So you put it in and you wait. It's the same with all of them. So when I'm using cord or cotton or Teflon or any of these things, just so that I can place the core so that it's not a bloodbath, that's tissue control, and they all take time. All of them take time. So at least 5 minutes, and if it's a bloodbath, you need 10. Now you need to go and do something. So if you've got if your office has many hygienists, go and do a hygiene check. If you don't have a hygienist to keep you busy, go and play on Facebook for 5 or 10 minutes. Do something, because if you sit there, you'll be tempted to have a look, and as soon as you pull it out too soon, it's going to bleed and you've got to start again. Okay, now, when it comes to retraction or tissue control, when do I use cord and when do I use Teflon? The 000, I only use 000 and 0. So the black cord and the purple cord from UltraPack. I use if I'm doing like a core build-up, I will use the thin cord where there's a risk of recession, because I don't want to go packing thick cords when there's very thin tissue, because it will recede. I'll use it for where there's just a little bit of bleeding. So often with these cases, you know, everything looks good and you get your air syringe and you blow high pressure air around the tooth and you get a little tiny bit of blood coming up. And you know that you can't do a core while that, because most of the time, for some of the easier crowns, I can put a rubber dam on, but a lot of time, if you're doing a big case with 4 or 5 teeth, I'm going to do the core build-ups with no rubber dam. So we're going to do old school, cotton rolls and suction. When I'm doing multiple cords, which is for impressions, so with impressions, unless they're veneers in a very healthy patient, I'm always going to put 2 cords in. And I'll explain why that's so important. And it has to do with the wettability of the silicone. So when I'm taking impressions, always the first cord, I'm going to have the 000. I'm not really going to pack 2 really thick cords, because the first cord just sits at the base of the sulcus and it stops the sulcus immediately collapsing. But more importantly, when you pull a cord out, it's very common for you to get bleeding if you've had to pack it with any sort of force, unless you're one of those dentists whose patients come to the hygienist 5 times just before you do the crown prep. Okay, but most of us don't work in offices like that, so we have to control the bleeding. So first cord stays in, and I'm going to use 000 for that. Now the question is, do I use it with Viscostat or without? Most of the time I'm going to use it with Viscostat, because most of the time I'm doing cord because the patient is at risk of bleeding. So I've trained you just put viscostat in a little Dappens dish, you pull the cord through, but most importantly you then have to dry it off, because if it's wet, if the cord is wet when you're trying to pack it, it doesn't go into the sulcus as well. If there was absolutely no bleeding, the tissue was absolutely perfectly healthy, and I was just packing a cord to push the gingiva or to stop a little bit of crevicular fluid coming up through the sulcus, then I would use it without viscostat. But I would say 90% of the time in my practice, I'm using this cord with viscostat. Be careful about how long it stays in the sulcus, because if you leave it too long, you can get recession. Thick cord, I'm really going to use this where the tissue is really thick, so you're not going to cause recession. Thick biotype, you're not going to cause recession, or where you've got plenty of buccal bone, you won't cause recession. Pretty much any time where the bleeding is heavier. So a lot of the times where you've prepped and you've prepped close to the gingiva and you've hit the gingiva with the burr, then you're going to use a thicker cord, and I'm going to soak it in viscostat as well. Now sometimes I will pack thick cord on its own just so I can place a core. So it's just to control the tissue while I'm placing a core. If I'm doing impressions with thick cord, I'm always going to pack a thin cord first. Otherwise, as soon as you pull the thick cord out, either the tissue collapses or it starts bleeding. And when I'm placing two cords, the second cord is always a thick one. I do sometimes use Teflon instead of a thick cord. So instead of having a second cord, I'll have Teflon over the top of the thin cord. I'll explain why that. Pretty much anything that's difficult, I'm going to use a thick cord. So you need the extra retraction, and occasionally where the tissue, sometimes on the distal of sevens, the second molars, the distal gingiva wants to fall over the margin. So it's so tall, unless you have periosurgery first to remove a big distal wedge, that tissue sits up higher than the margin. The tissue is not necessarily unhealthy, but it's tall and it will fall over the margin as you remove the cord. So there are occasional times we'll actually get a really long piece of the thicker cord, the zero, and wrap it around the tooth twice. Now Teflon. Teflon is cheaper than the other two. It is much harder to use. So if you've watched cases where you've seen other people use Teflon, don't be fooled. It will take you longer to put in. Teflon has this, it can drive you mad. Okay, you can push it in, and then you push the next spot and the first bit pops up and says hello, okay, and then you push that one down. It's like whack-a-mole. Doesn't matter where you hit it, it pops up somewhere else. So with apologies for those of you who have a pet mole and are upset about it being whacked. If you're using Teflon, you need to hold it down on one end, and usually with a perio probe, and you can use a fancy packer. I actually just use a flat plastic instrument for packing everything. I don't have a dedicated cord or Teflon packing instrument. I just use a flat plastic, and I get my dental assistant to hold the perio probe on one end if it keeps coming up. It does help a little bit if your tooth is dry and your instrument is wet, because the Teflon gets a lot of static electricity, and if you get static on it, it will stick. I usually roll mine up first to form it into a Teflon cord. Now, when do I use it? I use it when I want massive retraction. So now when you use this for the first time, you have to be a sadist, okay? You don't just put this in and go, oh, push it in gently. You got to, okay, push that in super hard and press it down super hard into and it will cause up to 2 millimeters of retraction. So you use it where you're trying to expose quite deep margins, where you are doing vertical crown preps because they're subgingival anyway. If there's going to be a lot of bleeding, I'll place a 000 viscostat soaked cord first, and then put the Teflon over the top. I almost always use Teflon for vertical preps because you need massive retraction compared. There are even occasional times where I'll put a thick cord over the top just to stop the tissue falling over the top of the Teflon, and you can sometimes use it as a prep guide. So when you are doing vertical preparations with safe-ended burrs, you can ride on the top of the Teflon. It won't helicopter like cord will. So you can ride around and it will stop you going too far subgingival. So it kind of acts like it maintains enough biologic width that you will not get inflammation afterwards. So that's retraction and tissue control, and then kind of the scheduling side of things. So they're probably some of the most important. The scheduling is super important, because if you don't give yourself enough time, you'll just panic, and then you'll cut all the corners, and then you'll have a dreadful time. Cores are actually really important. So I saw a post online today, do cores actually do anything? Okay, now, pretty much any time there's a corner to cut, someone will do science to prove that it's fine to cut the corner because it shows no significant difference clinically. And they'll do it at 5 years, okay? Let me give you an example. If I could do a scientific study that showed that crowns that hardly fit and have massive overhangs have no difference to their survival rate after 5 years, because if you cause massive perio issues, they don't usually show up for 5 years. So we could do a study to show that basically massively unhealthy crowns had the same survival rate as healthy crowns. But that doesn't mean we should. So survival rate and clinical significance in studies aren't always useful to us because almost nothing that we do will show up clinical significance. So we do incremental gains. Each little thing we do makes it easier and better. And none of those things individually are easy to measure. They're all, like little increments. So it's very hard to say which one caused the long-term survival of the crown. So what we do instead is we try and do the best that we can in every step. There's studies that show that if crowns fit really badly with huge 500 micron gaps at the margins, they have the same survival rate at 5 years as if they fit really nicely, okay? But what about 25 years? No one studies that. So let's try and make it fit as good as we can, regardless of what that particular study says. Now, part of doing cores really well and doing retraction really well and doing tissue control really well requires superb local anaesthetic, which I didn't put on the list. So local anaesthesia is incredibly important for getting each step of this process perfect, because you can't control the tissue without buccal and lingual anaesthesia or buccal and palatal anaesthesia. So if you're on an upper tooth and it's bleeding and you need to retract and it's not numb on the palate, then you won't be able to retract, and so you won't be able to control the tissue, you won't be able to get retraction, you won't be able to do a proper core build-up. So every step requires profound anaesthesia. Now, I'm not going to go over anaesthesia totally in this particular webinar, but there is a whole section in the online lecture which goes for a couple of days, which I'll talk about at the end. So to get the impression correctly, we need to have a core that is smooth, and that's because of the wettability of silicone, the contact angle with the tooth. And I'll explain that a little bit in a moment. Now, what if you're using an optical scanner? It's the same. A really nice, smooth prep is easy to scan without errors. As soon as you start getting really sharp points anywhere on a prep, it's hard to get silicone to flow around it, and it's hard to scan it. As soon as you start getting preps that are really rough, it's hard to get silicone to flow over it, and it's hard to get a scanner to scan it. So the core is important because it makes things smooth. Now, I guess you could just make it smooth and blobby. We'll come back to that. There is another reason to have cores that are beautiful. It makes life much easier for your technician. It makes it easier for almost all dental materials to be even thickness. It makes it easier for casting. It makes it easier for milling. It makes it easier for pressing. I have a technician up the road. Go and visit your technician and take them to preps and ask them which one is easier to work with, okay? If you have a big, sharp, jagged point, it's so easy to wear that, and then your crown sits high, and then you'll spend hours trying to get the crown to fit. So besides everything else, cores are incredibly important for getting your technician to think you're a good dentist. Now, I know for a fact, if you go and talk to your technician and walk around the lab, you can see how enthusiastic the technician is by how good the impressions are. So they go, I've heard the technician, not saying my technician or any, but I have heard a technician that I've used say, well, that's good enough for that dentist, look at his preps. So if you think that it doesn't matter your technician how good a work you send them, then you're fooling yourself. Now, I'm going to go through this core process step by step, and I use nothing fancy. There is no fancy equipment, there's no fancy materials, there's nothing that I don't use for everyday fillings, everyday things I'm just using for the cores. It's the same thing, and some of this we've talked about already. So you can see here, we've got the blood bath. This is quite common, and this was from today. I removed some of the old fillings. There's no way to prep down to those margins and clear them out without removing a bit of tissue, and then you get bleeding, and the tissue was inflamed to start with, so now we've got a blood bath. How do we control the tissue? So first of all, you can't see it all in this particular picture, but there is thick retraction cord on the distal of that tooth, and now I've got cotton that's soaked in Viscostat Clear, and I packed it in there, and then I went and did a consultation on the next room. So my hygienist, Caitlin, had a patient, and he was asking me about implants, so I went and did a consultation on implants. By the time I come back, the tissue is like this. Now, there is a lot of stain on this tooth. That's silver oxide, that is not caries. But you can see that this tooth is perfectly dry. So there's fluid on the tooth behind, but there is no fluid coming up over that margin. I've got plenty of time to bond a core. Now, here's the problem. The problem is when you have a hydrophilic substance on a hydrophilic surface, it's better if it's rough. But when you have a hydrophobic substance on a hydrophobic surface, it's better if it's smooth. So the contact angle of the silicone with the tooth is actually affected by how rough it is. And so don't go into this diagram too much, but basically when you have a hydrophobic surface that's rough, it is much harder for a hydrophobic liquid, which silicone is, or a hydrophilic liquid, any sort of liquid, to flow over the surface when it's rough. So the issue you have is that silicone is much more likely to get a bubble if your prep is rough. I'm not saying it has to be shiny, okay? That's just for Facebook, and I do that too, but you don't want to be cutting it with a black band burr that leaves giant grooves in it, okay? So, and it doesn't take very long to polish a tooth. Now I hear people, if you don't want to polish, here's what you'll say: it causes trauma to the tooth. That's nonsense, okay? I don't think there's ever been a tooth ever, unless you turn the water off and you create smoke signals with a thing, you're not going to cause trauma to the tooth, okay? If there's water on, you can have water going while you're polishing. You can use water with a Softlex disc, although I don't usually. I polish with a coarse Softlex disc, and then I use my standard polishing kit, which I use for composites. I don't go to superfine anymore. I used to, just to show off, but I don't care. I don't need to show off anymore. So I'm just going to polish it with a white cup, and then with my purple cup sometimes. I'll never go to the brown cup, which is the one that gives a super gloss to composite. If you want to see the polishing cups, I think Gail is going to send you, yes she is, she's going to send you the link at the end which has the full polishing kit that I use, so you can see exactly what they are and what their names are. They come from Kendra and One Gloss. So the polishing the core helps your silicone flow. So it is an important part of getting good impressions. Now, how do I do cores? I get asked this. I'm sure some of you have seen my webinars before, you have seen my lectures, you've heard me do talks on how I do cores. I get asked it every single week on Facebook. So I'm going to go through it for the half of you who haven't seen this or who've forgotten. I always use SE Bond 2 from Carrare. I have used this for 6 years, and the follow-ups are great. And I've cut off some crowns. Yes, I've had crowns break, and I've cut them off, and the core was still intact, and it was still very retentive. So what doesn't fall off, the core shouldn't fall off when you prep, okay? There's a problem with your bonding if you take an impression and the core falls off, or if you take your temporary off and the core falls off. So SE Bond 2, you just put the primer on. You just need to have the tooth dry. You don't get sensitivity, and then you dry it slowly. For all primers, you must dry slowly. This is very important. Then you rub on the SE Bond 2. Now, if you have your own bonding system which you love, then just keep using it. Don't change just because I said to. Well, I'm not telling you to change, I'm just telling you what I use. So SE Bond 2, I air thin it and cure it. The reason I air thin it is because I don't want to ever see an X-ray where I can't tell whether it's caries or the bonding agent. So if you leave bonding agent thick, it doesn't affect the actual strength, but when you take an X-ray, you can see a big black line, and it's impossible to tell whether that line is caries or if it's bonding agent. So I always thin it down. Okay, and then I cure that, and I use opaque white because often the black stain in your tooth, if you cut all that black stain out, there's often no tooth left. You are going to get a pulp exposure, or you're going to have a very weakened tooth, and there's no need to remove silver oxide. Silver oxide is not caries. But I don't want it shining through, because sometimes our ceramic crowns are a little bit translucent these days, and you can get it shining through. So I'm going to use something that's opaque to block. Okay, it looks nicer in photos, that's for sure, but generally when things look nice, they are nice. And so I don't want that black stain coming through. I have had crowns where you get the grey shadow in the middle of the fissure because the black stain was coming up through the core. I'm going to cure that. You need to cure these opaque things for quite a long time, otherwise because they're opaque, the light doesn't go through and cure as easily. And after I've cured the first layer, so you want to put enough opaque white flowable on to block out the black stain. And then I'm going to put another little bit of opaque white flowable, and I'm not going to cure it. I'm going to leave it wet. Because if you don't do this step, you'll get bubbles everywhere through your core. And then your impression will look like it's got the pox, okay? So now I use heated composite. Now I use Colteen Brilliant. I don't care what you use really. Any posterior composite is fine, or even probably anterior composite. You can use a dual cure, you can use core paste. I don't mind how you get it. But I just use my regular composite that I use for everything else. It's just to keep inventory consistent, and the staff get used to doing the same routine over and over again. So I just use it, but it has to be warm. So I heat it in a Kelset composite heater. So otherwise it's too crumbly. Most of the modern composites, if you don't heat them, when you inject them out, the composite crumbles and you get bubbles everywhere. So, so you need to have some uncured flowable, you inject over the top and you just make giant blob. So there's no matrix band. A lot of times I don't have rubber dam on, you just have giant blob, okay? Now, it doesn't take very long, so you need to control everything for about 30 seconds, 40 seconds to do this. It is fairly quick. And then you just use a microbush, or you can use a flat plastic, or you can use your finger, but you just want to shape it to a giant blob. I'll go through this step by step in a moment. And then you cure. Now, after you prep, you cure again, because you are curing through a fair thickness. It's not super thick. You don't need to worry about shrinkage because these are big open cavities. So the cavity factor or the C factor is usually 1 or 2. It's very low. So, but you are curing through a fair thickness of material. So when you finish the prep, cure it again and cure it with a bit of water or something. Otherwise, you can leave some uncured side chains, and you'll put your Pro Temp or Luxa Temp or Maxi Temp or some type of bisacryl on top if you use bisacryl. If you use acrylic, it's slightly less of a risk, but you'll put something on top and it will stick together, and then you end up with your temporary bonded to your crown prep, which is very depressing. Here is an example of giant blob cores, okay? So I've done this is the one I did today. It's 2 side by side. I did them one at a time, but you can see they end up joined together. Now don't just get in there and start prepping blindly. Start on the edge of that core, that blob, and start prepping in, okay? And here's that case. So on the left-hand side of the picture, those are the cores that I did in the preceding picture, okay? But I did all the other ones as well today. So those cores now give your tooth a nice, smooth, flowing shape, easy for silicone to run over. And if you're going to prep a margin, it's easy for it to run down the side and hit the margin and give you a nice crisp line. If you have a bumpy thing, it's much harder for the silicone to flow. Okay, it's not the end of the world. I'm sure you can make it work. It's just all these increments add up to getting the perfect impression first time. Now, one of the last things is retraction. When you retract, you need lateral retraction and you need it wide, and this is because, once again, it's to do with the surface tension of silicone running over the tooth. So silicone runs down the side of the tooth and then it will go into the sulcus, but it can't go into the sulcus easily if it's really thin. So if you've got a very tiny gap, it's very hard for the silicone to run down into that gap because the gap is too narrow. So silicone runs easily into a big fat sulcus, and it runs very difficult into a very skinny one. So that's why when you only use little tiny cords, sometimes you get the impression and sometimes you don't. So if you place a big fat cord like a 0 second, and then you push, you don't pack it down below the gingiva, you just pack it equal to the top and push the gingiva away. Now you're creating a big fat sulcus. It's very easy for silicone to flow into that big fat sulcus. Now you go, well, I use a scanner. If you use a scanner, it's very easy for the scanner to pick up. Scanners don't do well with big, deep, narrow holes. They scan very well in big, wide open areas, but they don't scan deep, narrow holes. That's why it's difficult to scan, say, a vertical preparation is very difficult to scan because the scanner doesn't see down into a vertical preparation easily. Scanners can't see down inside implants. That's why you have to put a scan body on top. Scanners don't work down in deep, narrow holes, and silicone doesn't like to go down into deep, narrow areas either. It wants to get a bubble. So if you have a narrow sulcus, then you get a bubble. So now the trick to getting good retraction is you pack the thick cord and you pack it equal with the margin so that you displace the gingiva laterally. And then most importantly, you wait at least 5 minutes. So you wait 5 minutes. If it was a bloodbath, then wait 10. Because there's no point pulling it. If you pull it out sooner, it will just collapse and then it will bleed. So just leave it in. If you leave thick cord soaked in viscostat for 10 minutes, it doesn't matter how much it was bleeding beforehand, you can pull it out and it won't bleed. Now the last thing is that when you lift the cord out, you don't just grab it and go and reef it out like that. You grab the cord and you very delicately lift it out around the tooth. Now when we get into multiple preps, it's a little bit trickier and I might not have time for that tonight. But pull the cord out very gently. Generally the assistant should be filling the tray before you start pulling the cord if it's a single tooth, because you want the tray going in as soon as you finish injecting. If you inject light body and the warmth of the mouth starts heating it up, the light body can start to set and then it won't flow properly. So you want to have the tray half filled before you start putting light body around the tooth. So what I get is my assistant tells me halfway. She starts filling the tray with the heavy body silicone. When the tray is half filled, she goes halfway. That tells me it's time to gently pull that cord out and start putting light body around. If you're doing 10 teeth, then it's a bit trickier because you need to start pulling the cords out before you start filling the tray. And that's when you need to leave the cord for quite a long time so that you can pull it out 10 minutes before you get to the impression. Well, not that long, but it would take a couple of minutes to pull all the cords out gently. If you pull them out too quickly, it's going to bleed. And then once you've pulled all the cords out, this is for say 10 preps, pull all the cords out, tell the assistant to start filling, they say halfway. By then you'll have injected light body everywhere. So choreography between you and the assistant for filling the tray is quite important. If you want it to, both those silicones to be at the same setting amount as they go in and push the light body down into the sulcus. Here's my cords that I use. So this is just an example. It's a prep I did recently. I'll go through this whole case a little bit later, step by step, but this case is getting ready for the impression. So there is a 000 cord packed first, and then there's the big fat 0 cord over the top, and then I waited about 5 minutes, okay? And then you've got enough displacement for the silicone to easily go down between the gingiva and the prep. Now, I'm showing you what I use here. I'm not going to tell you that you should all change to coltine. I'm definitely not saying that at all. I think that the most important thing about your impression material is that you have a lot of experience with it and that you're used to seeing that particular material, how it reacts, how it sets, how fast it sets, and so on. I'm just showing you that I use it. Now I use both heavy body and putty. If I'm doing a whole arch of crown preps, so where I've got 365-degree margins, I'm much more likely to use putty. Putty is not quite as accurate and you've got to be much more careful with how you mix it, so your assistant needs to be very well trained. It has to be used in a very robust tray because it will make the tray distort and then you will get preps that are too small. But if you're doing a whole mouthful of crown preps, I find the compression of putty is much better at forcing the light body into all the sulcus, and I tend to get the impression the first go more often than if I use heavy body when I'm trying to pick up 12 or 14 teeth all at once. Most of the time I'm going to use heavy body, so particularly veneers where you got those little edges on say the lingual side of the tooth. You really want to use the most accurate material you can, so I would tend to use heavy body here, and the compression of putty is not as useful on veneers. In fact, it's much more likely to get a tear or a distortion. Now your preps matter a lot, and I will show you a case later where the preps matter, because if you get, if your preps are too divergent, for instance, there's an undercut and the silicone can't flow easily into undercuts. Silicone is dead soft, so it goes straight down or out, but it doesn't go in underneath undercuts very easily. So that's when I would use putty and when I would use heavy body. You can use whatever material you are comfortable with. Just don't use materials where the heavy body is really runny. It has to be quite stiff, otherwise it will not push things in. Trays, I hardly ever use custom trays. So I used custom trays when I was trained. I hardly ever use them now. Mostly I use that 3M tray that you can see on the screen there. It is a border lock disposable tray. You could use a metal. You could use a metal border lock tray. So if you are in an area where you can't throw out 3M trays all the time because they're too expensive, then just get a metal border lock tray. But never ever get a border lock metal tray, a solid metal tray, stuck in the mouth. Okay, I've cut a metal tray out of the mouth and it takes 45 minutes with a tungsten carbide and it's extremely stressful for both you and the patient, and heaven help you if they're a gagger who vomits. Okay, it would be an absolute, you would probably retire from dentistry immediately and take up painting toenails or something. So obviously before you take, if you're going to use a metal tray with putty or heavy body, look for black triangles. If there's more than about 7 or 8 black triangles, you ain't never getting that impression out unless you are a beast. And if the patient's got any sort of mobility, they'll have an extra grade of mobility once you finish. So that's my only concern with metal trays. Plastic trays are hard to get out too. You mostly get impressions stuck early in your career because you're too gentle. Later on in your career, you hardly ever get them stuck because you just go, okay, these teeth, something's coming out. So that's just my advice on trays. I use the metal tray. If I'm using putty, I'll often use a metal tray with perforations just because I want something super rigid that won't distort when I'm pushing that putty down, because the putty can be really, you get massive resistance as you're pushing it down. That's why it gives good impressions, okay? But it's also why it can distort your tray. You definitely can't use putty in like your standard flimsy disposable tray. Now I'll go through some cases to just demonstrate some of these things. So I won't go through every type of case, but I'll go through some. So we'll go through 3/4 veneers. Now, why are we doing 3/4 veneers for this case? Because there's black triangles, the patient doesn't like them. If you try and do standard labial insertion veneers without going through the contact, you will end up with massive calculus traps on the lingual. So they'll be uncleanable and you will have preserved tooth structure at the expense of periodontal health. So now we go through, this is the mock-up. So that was just a mock-up because this particular patient, it was too small a case to bother getting a wax up. I can do a mock-up like this in 10 minutes, so it's easier. And if a dentist says 10 minutes, what does he actually mean? Probably 20, okay? We always say 10 minutes faster than we really are. So I did a mock-up in this case. It's basically like my wax up. That part doesn't really matter too much as far as the actual impressions go, but now we get to the parts of the procedure that does. So core build-ups. I need to have nice smooth preps so that I can get the silicone to flow. So we're going to need to do core build-ups. So you can see I've done core build-ups there just with the same resin that I use for every other type of filling. And then we're going to prep. Now after I prepped here, I got things smooth, flowing as I could, and then we polished the teeth. So polished with my usual polishing cups that I use for composites, and you'll have that in the link. I don't necessarily need to have them glossy. Sometimes I'm bored and I'll do them glossy because I know it looks good in photos, but it doesn't have to be glossy, and there's probably some benefit in having them just like a little, not shiny, okay? If you're shiny, then you've got to sandblast them and roughen them up again to bond, because you lose some of your bonding strength when you've got super mirror shiny. And remember that your adhesive loses half its strength after a few years. So you want a little bit of resistance form and retention if you can get it. Now in this case it's veneers, the tissue is super healthy. Is it at risk of recession? Absolutely. Am I going to pack 2 cords when there's risk of recession? Definitely not. Definitely no fat cord. Definitely not using a thick cord in this case, because if I use a thick cord with delicate tissue like this, I'll definitely cause recession. So the key parts for this were, one thing I forgot to show you is the prep. If I go back a little bit, okay, maybe here. Righto, so this picture here, you can see that the lateral incisor on the 3-2 is inclined distally. Now, what happens is if you have the lateral incisors too divergent, it's very difficult to get silicone to flow into those undercuts. So I took this photo. You see a lot of things in photos. I took the photo and then I noticed that there was this divergence and I was going to have trouble getting the impression, and also the impression would likely tear or pull when it came out. So I corrected it between the last photo and this photo. So one of the things I did there was just correct divergence if you can. I took a little bit off the distal of that tooth so that they were all a little bit more parallel. And then, yes, we got the impression first go. Now, do I always get impressions first go? No, I don't. But when I do the steps correctly, I get them first go very often. What about if you have recession? So recession is tricky because you basically have no margin. So when you have recession like this, a lot of it comes down to the core buildup. This case is easy from the occlusal, but from the buccal it's harder. So same steps, we do the reduction, we're going to do the core buildup. So you can see we've done the big blob of composite core buildup, okay? And then we prep single chord with the 000 chord first, then the second chord with the 0 fat chord, and then we wait. Very important, we wait, and there we go. This impression came out first time. That big recession defect I had to fill in with the core buildup, otherwise I just have a great big undercut there. Implants are very similar to crown preps. The one difference with implants is you want retraction and you need moisture control. So you cannot get a really good impression of implants if there's any moisture anywhere. So controlling saliva with implant impression is incredibly important. I use a tray from Hagen and Werker, I think it is. I'll find a link and get it sent to you later. It is called a mirror tray. It is a stiff plastic tray, but it's got a clear foil on the back. So you don't have to drill holes in it. It's a stock tray, works with 99% of implant cases, and just push it in. Now, what's important with trays is most of the time I'm using a tray that's not perforated. You want a tray that is solid because it compresses the silicone in better. So for something like this, okay, we go through. Part of the difficulty with impressions is you want that really crisp capture of the soft tissue around your implants. And to do that, you actually need to have healthy tissue that's not mobile. So if your tissue is mobile or wobbly and a little bit thin, you're quite likely to get kind of a lot of fluid coming up around the base of the abutment, and so you get these little drags there. So creating some attached tissue with implants is important. In this case, I did that simply by doing an apical reposition flap, and then we come up to the impression. And this impression was so crisp around we want it crisp around the implants because there's no movement, we know there's no saliva. We get that by having an Optrogate in, and we have one assistant helping us dry the teeth or holding the small suction in, and it comes out just as the light body and the heavy body go into the mouth. So if you keep it all perfectly dry and inject light body everywhere, then you'll get this crisp capture of the abutments. But if you let moisture get everywhere, then you get drags. You get drag around it, and then you implant abutment wobbles. And I had one recently where I got a cantilever bridge made, something's wobbled, the lateral incisor is sitting out in space. Okay, so any time that I saved by rushing that impression or not checking with a radiograph or whatever it was that I did has been completely lost by the fact that I've got a complete remake to pay for on a 2-unit implant bridge. Deep bleeding. So when you do, some people will say you never do subgingival, you just do crown lengthening on everything. That's not realistic in 99% of our practices. But if you do vertical preparations, you are definitely going to do deep subgingival margins at some point where it is a bloodbath. So here's a typical case. It looks like this, but when we take out the core, the previous restoration, we see it's suddenly really deep. So we thought it was okay, but suddenly it's really deep. So first of all, we've got to control the tissue. So there we go, we've got some cord in there, thick cord soaked in Viscostat, really packed hard, and then there is some cotton wool sitting on top. It's also soaked in Viscostat, it's packed hard as well, and then we wait. Okay, so we wait some time. Here we can pull it out and you see there's no bleeding. I can blow air in there, I can blow water, I can do anything, there's no bleeding at all. It has stopped bleeding. So now I can do a core build-up even though it's subgingival. There you go. If you can take photos of it dry like this, then it stopped bleeding because it takes a while to line the camera up, particularly if you use complex fascias. So now we do our giant blob of resin, core build-up. And in this case, I'm doing a vertical preparation. So we know that it is going to be a bloodbath again. So it's the second time today for the same tooth. And how do we do that? Should we just put it? You can put a temporary on and wait, but then the tissue will be delicate. So you'll need to wait for at least 6 weeks. And even then, if you pack a cord at that point, it can start bleeding again. So we may as well, if we can, take the impression now. There are some times when you can't, and if you can't take the impression, just put a temporary on and come back. So in this case, I've packed thin 000 cord, soaked in Viscostat, I've packed thick cord on top, and then I waited, and bang, impression first go. Those bubbles are not consequential because there's a vertical margin, so they're going way past the actual margin. The prep goes further than the crown does. What about fine chamfers? Fine chamfers can be quite difficult because you do need to actually pick up the line of the chamfer, and it has to be crisp, but it's easy to miss because it's if you've got a big fat shoulder, it's actually easier to tell whether the silicone has hit it, whereas when you've got fine, it's easier to get a little drag and not notice. You'll notice that this is just a repetition. It's just the same thing over and over. We take it out, okay? That's super deep subgingival there on the lingual and the distal. That's why we're replacing the crown. So in this particular case, I've packed Teflon just to do the core buildup. So I wanted the most retraction I could get, and I wanted compression of the tissue to stop bleeding. So in this case, there's my big blob of composite. Okay, now when I prepped, now we have bleeding again. It's prepped with a chamfer, so the outside edge of the burr is going to hit the tissue a little bit. Try and do the bit close to the tissue with a finer burr if you can, but you can't always. Sometimes you have to use your coarse burr and it's going to bleed. So you can see once again, I've got the cotton soaked in Viscostat, pushed in there. We wait 5 or 10 minutes and then it's like this. Easy to take a perfect impression, bang. First go, and there's the dye. So it's just a routine, okay? What's hard about it? It's hard up here because we want to skip the steps. It's mentally difficult. It's not difficult from a concept point of view. Deep, this is a very deep margin again on the distal, and the tissue was inflamed. We were doing a gold post and core. On the distal there, it's about 1.5 millimeter subgingival, and it was bleeding like crazy. This one, I probably should have put a temporary crown on and come back because it would have been quicker. But once again, thin cord, packed in there, thick cord, and sometimes after the thick cord is in, you need to put cotton as well and wait even for the impression. Okay, but then we got the impression. This is a vertical preparation, so once again, you're trying to capture something quite subgingival, even though the crown won't necessarily go that deep. So you start to see it's just a routine. Now, when we get into full arch stuff, it becomes amplified and we can have a human factor issue, which is panic. It's easy to panic, go, oh, I don't know if I can get this impression first go, and then you start to panic, and then you start doing stuff crazy without thinking about it, and you just follow the steps. So don't panic, just follow the steps. So once again, same thing. We've got to have cores, big blob of composite, we build it up, we have to get tissue control on the deeper margins, then thin cord in place, and then thick cord in place, and it's very important to wait with a full arch prep. So full arch preps, because you definitely don't want any bleeding, you don't want tissue collapse, you don't want anything happening. It's super important to wait so that you know the tissue is not going to collapse on you, okay? And this impression, I got first go, so all 9 teeth. Obviously it gets harder if you start adding the posterior teeth as well, but it's the same process, and you just go through it. Now, I will tell you that in that case there's probably 35 minutes just spent packing cord. But it takes, it takes a long time to retake impressions, and often you end up with an impression that's bad, so why not just take the time? Just book enough time. Now, I'm going to take questions and answers in the moment, but I've got a gift for you tonight. So I have 10 hours of lecture content on this particular topic and posterior dentistry, which is going up onto our academy in the next month or so. Now, it will normally be about 900 Australian dollars. For you watching tonight, it will be about 450. So go on to there's a coupon that's coming out, and there's a link that you'll get. So if you want to get that for the next 3 days, you can get that massive saving on that. The people who came to the lecture paid about $1,500 plus airfare, so it would normally cost about $2,500 to get all this content. So I can't travel everywhere in the world where people want me to lecture anymore. I get asked to about 50 countries a year. I get tired of sitting on planes, so I'm doing it this way so that you can still get the content and I can still stay home a bit more often. If you save yourself just probably 2 or 3 crowns that had to be remade, or impressions that you had to retake, you've paid for it already. So go and check that out. Now, if you have questions, please put them in the box. I've got to go and grab my phone, and Gail's going to send the questions through to me. So if you have questions, I'll be back in a moment. I had to put my phone off during the webinar because otherwise it buzzes and I get really annoyed by phones buzzing. There's nothing worse when you tell all your staff off for having a buzzy phone and then it's your own. Okay, now Waleed has sent through a question. How about packing cotton pellets soaked in hydrogen peroxide? Can it help stop bleeding? It can help stop bleeding, but it doesn't do a very good job. So compared to using Viscostat Clear, it's not even close. I used to use hydrogen peroxide. Hydrogen peroxide was, yeah, it's not very good. Okay, yes, you can use it. You can, if you use the 10%, like the superoxyl, it will help a little bit, but hydrogen peroxide is not really that great for anything much. Okay, I can't think of anything that it's really good for with restorative dentistry. So I would just use Viscostat Clear or some type of aluminium chloride. If you're in a country where Viscostat Clear is hard to get hold of, then use whatever other brand of aluminium chloride is useful for you. Otherwise, go to a compounding pharmacist and get them to put aluminium chloride in a gel and find out what the concentration of Viscostat Clear is. If you're in a heavily regulated country like Australia or the UK or the US, don't make your own, okay? It's a bad idea. John has said, what are your thoughts on the use of pins for the retention of cores? My thoughts are that that's a silly idea. Pins very rarely add anything to teeth except cracks and pulp exposures. So if you can't bond a core that will actually stay on, then either you don't have enough tooth structure or you don't have proper bonding, in which case you don't want your core held on. The only time I would use pins is if you're going to use amalgam. So I don't use amalgam, but if you're going to use pins, I would use amalgam because then you're not relying on the bonding agent. You're just relying on the mechanical retention. Do crown lengthening, okay? Then get some more structure. Dr. Aditi, which material and tray do you suggest for severe soft tissue undercuts? Does a 2-take with putty, spacer, and then light body work? I've never really had a problem with big soft tissue undercuts when I'm using silicone. The only time I've had a problem with undercuts, and to be fair, I've never done someone who's got a cleft up through their palate into their nose or any sort of massive things like that. But when I'm using a stock tray, they don't fit close enough to the soft tissue area to get retention or get an impression stuck from the undercuts. So I would suggest don't use putty if you've got undercuts, just use your normal heavy body. I think you'll get it out for any soft tissue undercut. Now, the undercuts I worry about are, the only ones that concern me are black triangles. If you have black triangles or where you've got a missing lower molar and the 2 adjacent teeth have fallen in like this, then the tissue will flow, the silicone will flow in underneath and you'll get it trapped in that sort of triangular area. And that's when you can have trouble getting your impressions out without. But normally if you can't get your impressions out, it's because of black triangles. Now there's a very important thing to do with veneers. Sometimes when you're doing a veneer that seats from the facial, you actually do have a little black triangle there, which the patient doesn't care about and you don't care about. And what happens when you take the impression for those cases is that the impression tears interproximally and it tears over the margin. So if you have black triangles on a veneer case that you aren't going to open the contacts, then you need to get flowable and block them out from the palatal side or the lingual side. Not over the margin, but just enough so the silicone doesn't flow between the teeth. And that way the silicone, because I've taken veneer impressions like 9 times trying to get, and they just keep tearing and tearing and tearing until it finally dawned on me I'd never get them because the silicone flows down through the black triangle out the other side and then it's going to tear every time you take the impression out. So those cases you need to block out from the palatal or the lingual with some flowable and then cure it. Okay. Now, as far as whether you take single step or 2-step, I don't really care. It's whatever you are comfortable with and have done a lot. I have friends who have only ever done 2-step impressions, so they take a putty impression and then they reline it. There's people who say, but there's studies that show that it's not as accurate. Those studies are in vitro, they're not in vivo. So, you know, I know good dentists who do it both ways. I always take single step because theoretically I like both my silicones set at the same time because then I don't get so much distortion theoretically, but that's theoretical and we can't say that that actually makes any difference to the clinical outcome. I I don't think that whether it's 1-step or 2-step makes any difference. What matters, as you noticed with this presentation, what matters is things like having enough time, polishing your preps, doing nice core build-ups, fat cord to push the tissue away. Those things matter. How you put the silicone on doesn't matter so much. Okay, this is from Jordan. I know a few prosthodontists that blow air with their triplex on light body once they have injected around the margins to ensure the light body is well within the sulcus. Have you tried this and what are your experiences? I find that it makes no difference. You're hopeful, okay? You're living in hope. You're hoping that the silicone will go down there and it won't. So if you want silicone to go down, I do that quite often. But if you want silicone to go down into the sulcus, you need to push the sulcus, you need to push the gingiva away from the margin of the tooth. Then the silicone has enough room to go down and you don't have these whole problems with wetting or contact angle. So blowing air, I do it because I live in hope too. I live in hope that one day there will be an easy way to take impressions, but there's not. Okay, it's from Zaid. So how much viscostat can be used without causing recession? It doesn't actually matter how much you use, it matters how long you use it. So if you use it in thin tissue and you leave it in there for more than 10 minutes, then you may cause recession. So thin tissue is difficult. If you've got a huge risk, if recession is a huge risk for you, do a soft tissue graft beforehand, okay? Because if you do, sometimes when you have thin tissue, the tissue itself retracts quite easily just by doing hardly anything. So when you have really thin tissue, often where you need the retraction is on the mesial, distal and the lingual and none on the buccal. So those cases, instead of putting the cord all the way around, you would just start on the distal, go around the lingual and to the mesial and not do a full circle with the tail like I normally do. So that's how you can avoid recession if the tissue is really thin. This is from Rizvi. What are your thoughts on plastic triple trays for single crown impressions? Plastic ones I think are rubbish. Most single posterior crowns, I use a heavy, it's a metal triple tray called a Quad Tray Extreme. Gail, can you send them a link with the type of triple tray that we use? It has got really heavy metal frame, it's still pretty cheap. You can't distort it because it's so, and if the patient tries to bite on the triple tray, which is a big risk with triple trays, it's so thick that they can't close their mouth. So you can tell if they're bit on the actual frame, it won't close. And if I'm doing a single tooth with a triple tray, I will nearly always use putty, but putty takes a lot of training for your staff. Okay, hi, is there a difference between stain dentine and silver oxide you refer to? How much stain dentine and silver oxide do you remove for good composite resin bonding? So there's going to be some parts of the dentine that you really can't bond to no matter what you do because it is sclerosed. Maybe air abrading it will help a little bit, probably doesn't. I find that I get good bonding with the SE Bond, but generally with a core build-up, unless I'm worried about a pulp exposure, I'm going to use a slow burr, not the diamond burr, but a slow burr, and I'm going to remove anything that's not hard. So if it's black but it's hard, that's as much as I'm going to remove. If I'm over the pulp, then I might be a bit less aggressive, but otherwise if I'm far enough away from the pulp, I'm going to remove everything until it's hard for core build-ups. Why do drags come on impression sometimes, especially when patients with anterior proclination? So if you've got anterior proclination, what happens is that your tooth leans forward like this. I'm going to have to put this down for a moment. Okay, your tooth leans forward like this and you put the tray in. The silicone can't go round corners. Silicone is dead soft. It can only go vertical or out. It can't go in. So if you have teeth that are proclined, you need to seat the tray from the front or lift the patient's lip up and inject a huge amount of light body up under their lip first to fill in that area. There is no way that you're going to get silicone to go up over the incisal edge and then back. So either seat your tray backwards or inject a whole lot of light body up there, or do both. So that's how you deal with proclinations. Now the main reason you get drags is because the teeth are not dry. So mostly when you get drags up near the back, it's because either you got a trapped air bubble or you got, most likely there's a bit of saliva on the tooth, and as you put the impression in, it pushed the saliva off the teeth. So that's why you get drags most of the time. Polyether, what's your thoughts on using polyether impression materials? So what is the name of the polyether material? Someone sent it to me in a comment, I forget. There's one that's quite famous. Can't remember it, but anyway, it is excellent for impressions. It's excellent for impressions of implants in particular because it's very stiff. Some people love it for doing full arch impressions. You just got to be more careful with polyethers because they are less stable when you soak them in disinfectant, and they have to be poured up more quickly because they can distort after a certain amount of time. Okay, I think this might be my last question for now. In cases of crowning teeth with cervical abrasion, do you normally restore the cervical lesion and then extend the crown? Yes, I do. Okay, so I always build up the composite resin and then I drop the margin down to the tissue. So generally though, I mean, sometimes you can graft upwards, but a lot of times if they've lost the papilla, you're never going to soft tissue graft over that recession lesion. So yes, I'm going to drop the margin down. If you can control their brushing, they generally won't get recession a second time. I personally think that occlusion doesn't cause cervical lesions in very many cases. It's mostly toothbrushing. Well, it's not the toothbrush, it's toothbrush plus the abrasion of the dentifrice. So I don't leave composite resin because if you leave composite, I've tried leaving composite resin under a crown margin and the composite resin gets washed away by the toothbrush and then you end up with a big undercut under your crown margin, and I've had to replace crowns for doing that. So I think that's enough for now. It's getting late here, so thank you so much for watching. Please tell your friends if you enjoyed this. And the replay will be available to you for those of you who signed up. And we'll be having another webinar in, how long is it, Gail? In about 8 weeks' time. So we'll send you a link when we're ready for that one. So I hope you enjoyed it, and thank you so much for watching.